everyone. Good afternoon. The next talk is we're going to look at rosacea, and we're very pleased to welcome Professor Anne-Marie Tobin. Professor Tobin is a consultant dermatologist at Tallaght Hospital and a clinical senior lecturer in Trinity College, Dublin. And as with all our talks, Professor Tobin will be taking your questions, and we'll come to those questions at the end of this session, at the end of this talk, if there's anything you'd like to raise with her. So welcome along, Professor Tobin, and thank you for joining us today.
Thanks, Claire. So, good afternoon, everyone. So, what I'm going to do in this talk is, I've no conflicts of interest, sadly. I'm going to cover what rosacea is, what causes rosacea, and how do we manage rosacea, and then leave plenty of time for questions and answers afterwards. So rosacea has been around for a very long time, and it's something that is featured a lot in art and also in literature. So Shakespeare has mentioned rosacea, and the building isn't open, but if you went across here to the Charles Institute, which is the research institute in dermatology, that picture is actually up on the wall. So it's been around for a very long time, and loads of famous people have had rosacea. So Bill Clinton, you know, you wouldn't mistake that. Princess Diana had rosacea. So if you go online and look up, there's even a sort of a website, Rosacea on the Red Carpet. So it's been around for quite a long time. So we think that about 10% of the population have rosacea, and it varies across the world. So in Ireland, Scotland, and in Sweden, they have the highest prevalence of rosacea. And the reason is we have that lovely, fair Irish Celtic skin. The other name for rosacea is the curse of the Celts. Whereas if you look in America, where there's much more of a mix of skin types, only about 1% of the population have rosacea. And even in Ireland, if you look at the population, there's more patients with rosacea living on the western seaboard and on the islands compared to the eastern coast. And it's associated with, one, the fair skin type, and two, being outdoors and outdoors work. Usually comes on between 40 and 60 years of age, but it can also occur in younger patients, and it can sometimes get mistaken for acne in younger patients. Tends to have a female predominance, so about a 2 to 3 to 1, so about 3 times more women get rosacea than men. However, the men are more likely to get those, what we call phymatous changes. And that's where the skin thickens up, and you've heard the expression whiskey nose. So the men tend to get that type of rosacea. So the typical patient is fair-skinned, and 75% of the Irish population are fair-skinned. So if you go onto the Irish Cancer Society website, you can look up this, it's a quiz that you can take, and it is what's known as your Fitzpatrick skin type. And it really is how you react to the sun. So Fitzpatrick skin type, 1, always burns in the sun, never tans. 2, burns but may tan. And then 3 is more likely to tan than burn. But 75% of the Irish population are skin type 1 or 2. It can occur, however, in any race or ethnic background. And the problem with darker skinned patients is it may be difficult to diagnose because the redness, which is sort of the key feature of rosacea, may actually be harder to diagnose. So the other thing is that there's an awful lot of patients, or an awful lot of the population walking around with rosacea that hasn't been diagnosed. So There's 4 different types of rosacea, and the nice thing about it is that each of the type describes what's actually happening in the skin. So the most common thing to change or to occur in your skin when you develop rosacea is redness and flushing. Now the redness persists, it stays there, but the flushing can come and go. So someone will go from a cold environment, they'll walk into a warm pub and they'll flush bright red. And I think this can be one of the most distressing features of rosacea, and particularly when you think of how much we've switched to Zoom for meetings, it's that flushing or blushing. And in fact, that was the type of rosacea that Diana had. So, you know, she was called this blushing bride. In fact, that was flushing. And there's some quite interesting articles about how she and her makeup artists compensated for it. So the key thing about, because you can get different types of rashes on your face, but the key redness with rosacea, it doesn't go around the eyes, and it doesn't go around the nose, or you can see the mouth is clear there. So that's the first type. The second type is where you get the redness and the flushing, but you also have these little inflammatory lesions, these little red bumps or white pimples. So they're small, fine pimples. So if you look up at that lady's forehead, you can see the background redness, but you can see there's a good example of a pustule then. And then you also get these red bumps, so they don't have a white head in them. So the pustules have a white head in them, but the red bumps, they don't, and they're called papules. And the thing about rosacea, which I think we overlook as physicians, is that rosacea can be very burning and stinging, and patients have really sensitive skin to add into the mix of the condition. So this is another example, and you see those kind of fine pustules there, and then you have these red bumps. So that's what's known as papulopustular rosacea. So then you're moving on to the third type, or the third change that can happen with rosacea. And this is what we call phymatous changes. And what that means is the tissue, the top layer and the deeper layer of skins becomes swollen and scars at quite a deep level. So you get this thickened skin. And typically the nose and also the chin can be affected. And when it affects the nose, rhino is just Latin for nose, it's called rhinophyma. And the issue about that is it can be poorly responsive to treatment, and often these patients will require surgery to actually debulk the tissue. There's another example of in profile. And, you know, you do see people like that still, unfortunately. And then the other thing, thing that can happen in rosacea is that rosacea can affect your eyes. And it can give you a sense of dryness and grittiness, so almost like you've a speck of dust in your eye. And, you know, people with rosacea of their eyes they weep, or their eyes tend to cry. It's like having hay fever. They can water, actually, that's the correct word. And also the front of the eye can look red. So here you can see the white part of the eye can look red. And what you see is inflammation along the eyelashes. And it's important to recognize that, because it can lead to chronic changes at the front of the eye. Now, there are rarer types of rosacea, but they are very rare. So occasionally, and the ones that I've come across, I can really only think of about 5 patients with this very, very severe, it's called rosacea fulminans, were all ladies who kind of developed in pregnancy. So extremely inflammatory plaques, you know, these big red patches all over the skin. There's another poor lady with it, and they require kind of almost urgent treatment and quite a different mode of treatment, but fortunately extremely, extremely rare. Another thing to just bear in mind is that rosacea can affect the scalp, so particularly gentlemen who are going thin on top, important to wear a hat because you can get these very little fine pustules studded throughout the scalp. The other thing is you can get steroid-induced rosacea. So in patients who mistakenly have put very potent steroid creams on their face, or they've been given a course of steroids, for example, if they have an asthma attack or a respiratory tract infection for which they need steroids, it can induce rosacea, or it can cause rosacea on the face, but it's quite different to normal rosacea in that it tends to involve, it comes in around the nose, which you don't really see in typical rosacea, and the spots tend to be the same size. And that's very easily managed and reversed, usually with a course of oral antibiotics. The other thing to mention is that it's like the old adage, you almost never get one without the other. Patients who have rosacea very commonly have another inflammatory thing going on their face and scalp, where they're getting flaky skin around the edge of their hairline, their eyebrows, and around their nose, and almost like quite thick dandruff in their hair. And it's caused by a yeast in our skin called Malassezia, and we all have it on our skin. It's just the changes that happen on patients who get rosacea also tends to favor developing or letting this yeast called Malassezia overgrow in the skin. And it can be confusing because you can have the background redness of the rosacea and the red bumps and pustules, and yet you have this scaliness around the nose and around the eyebrows. So that's a good example. Here you can see, that scaliness down the nose. That's the background redness and telangiectasia of rosacea, and that's kind of a patient with more red telangiectatic rosacea. So this is what rosacea is not. It's not contagious and it's not poor hygiene. It's not an infectious disorder, it's an inflammatory disorder of the face. It's not the same as acne. So it used to be called acne rosacea, but it's different to acne. And if you're trying to figure out, do I have rosacea or do I have acne? The key difference is in acne, you will see what's known as comedones. So comedones are the little openings of the hair follicles, and when they're open, they're blackheads, and when they're closed, they're whiteheads. You won't see those in rosacea, and you will see them in acne. The other thing is rosacea cannot be cured in that you always have the tendency to have it, but it can be managed with proper care and treatment. So if we consider what causes rosacea, there's kind of two different types or two different factors which leads to rosacea. There's things on the inside like genetics. So you tend to inherit this skin type from your parents. So often your mom or dad might have had rosacea. And then the impaired skin barrier just means that the surface of your skin changes so that you don't handle things like Malassezia the way a normal person does. And what the vascular and nerve changes are about is that your blood vessels at the very surface of your skin become much more reactive, and that gives rise to the flushing. And then the external factors which cause rosacea, and the two main contributing factors are exposure to sunlight or exposure to UV light, and then this little microbe known as Demodex mites. So the top ones are the things you can't do a lot about. These two you can. And the other thing, because of this, there's a number of factors which contribute to rosacea. So there isn't one thing that you can take, unlike other skin disorders like psoriasis and eczema, you can take something that kind of switches it off. Most of rosacea is actually about treating the disease symptoms rather than targeting the disease itself. So if we look at UV light, so we think that UV, and there's an important difference. UV light means daylight. It's irrelevant if the sun is out or not. It's the amount of UV radiation that you're getting at ground level. And you're getting enough of that between the 1st of April to the end of September in Ireland, even on a cloudy day. And we think that the UV light causes inflammation of the skin. So what neoangiogenesis means is you begin to grow more of those small little blood vessels on the surface of your skin that gives rise to the telangiectasia, those tiny little blood vessels that give you the background redness. And that you also get thickening and hardening of the skin from the sun. And we know about the thickening and the hardening because there's a thing called solar elastosis, which is what you get if someone, I shall have a picture of it later on, if someone has been exposed to sunlight over a long period of time, the skin hardens and toughens. My mother used to call it getting drills in her face, so it's a good description. And we also think that UV light may actually cause or may be the initiating factor in rosacea. So then we move on to this little fellow called the Demodex mite. And when you mention this, people are horrified. But all of us here have in fact, we have two of them on our skin. And like malassezia, it's a completely normal component of our skin. So we have these tiny little mites called Demodex. And there's Demodex folliculorum, which are on your face in the hair follicles. And then we also have these other smaller ones which live in the sebaceous glands, which are kind of down. They're an oil gland that feeds into the hair follicle. So everyone here, and I could go around and do a little strip test on all of you, and I would find Demodex mites. But for some reason, in patients with rosacea, they seem to be able to overgrow, and you find them in a lot higher numbers. And one of the treatments which we will come on to, which targets mites, is proving to be quite an effective treatment for rosacea. So now you've one piece of homework from the talk, and this is to go and look up these videos on YouTube called The Dancing Demodex Mites. It's perfect for a rainy Saturday afternoon. So then moving on to how do you manage or how do you look after your skin with rosacea? So the first thing is be very gentle with your skin. Don't scrub the skin. I'm not a huge fan of exfoliants or scrubs because most Irish people have such beautiful, fair, sensitive skin. Use a gentle soap-free cleanser and apply it with your fingertips and just pat it onto the skin. If possible, men should use electric razors as they tend to be less irritating, and you may use less shaving cream or lotions because they tend to have a lot of perfume in them, and the other thing they can have is a lot of alcohol in them, which is quite stingy when it's put onto rosacea. Apply a gentle moisturizer because what you're trying to do is restore or repair your skin barrier. Again, soap-free and oil-free. You don't want a thick, heavy moisturizer on your face. Now, applying sunscreen. So are you sick of sunscreen by now, or will I go through this with you? So a teaspoon of sunscreen to cover your face in the morning. We apply it during the day. Now, if people have kind of layers, if they have makeup on or whatever, that's not obviously possible. But even once during the day, particularly for men working outdoors, just keep a tube of sunblock or a bottle of sunblock in the door of your Jeep or the tractor, whatever, and put it on again during the day. The order is, there's always great debate about what you should do first. Moisturizer first, then your sunscreen, and then your makeup. And the other thing is, don't forget your neck. So treat your neck the same way as you would treat your face. So just with regard to sunscreens, because there can be a little bit of confusion about the sunscreens. So there's two types of light, UV light, that we are exposed to. 95% of what we get is UVA radiation, and that's the type of radiation that can cause changes in your cells and potentially skin cancers. And then the other 5% is UVB radiation, and that's the one that gives you sunburn. So when you look at a sunblock, there's two things you should be looking at. The SPF is what's going to protect you from UVB light, and then you should be looking at the star rating, which is this kind of circular symbol that will be at the bottom on the front of the bottle. And that's what's going to protect you from UVA. So you should be looking for at least SPF 30 with 4 to 5 stars. The other thing is there's two types of sunscreen to use. So there's those that use chemicals to block the sunlight, and they use things called chromophores. So they actually absorb the sun and prevent it getting to your skin. And there's all sorts of, there's different families of chemicals that they can use as sunscreen. So some of the more well-known ones are benzophenanes, cinemates, and then Tinasorb is kind of it's a branded chemical sunscreen. And then there are these other ones. So these are physical sunblocks, and these contain zinc or titanium dioxide. And the thinking until recently was actually they bounced the light back, but in fact, they do absorb it as well. So they contain, because they're not a chemical, they don't need stabilizing agents, or they don't need, there's often a lot less chemicals in the physical sunblocks, so they can be better tolerated. And I sometimes think they give better protection actually than the chemical sunblocks. Just in general on sun protection, you should really only be relying on a sunblock for your face and neck, and for the rest, cover up using long clothing. You know, it's the same with children. You cannot run after children and apply sunblock. So you use clothing for the body, and you're only relying then on the sunscreen for your face, neck, and the back of your hands. The other thing to note about sunblocks is, well, two things actually. You don't need to spend a lot of money on sunblocks. There are perfectly good sunblocks in all the supermarkets. So if you wish to spend on one, you know, for a cosmetic purpose, all well and good, but you really don't have to spend a lot of money. There is one thing though, when April comes around, don't reach into the back of the cupboard or the bathroom cupboard and pull out an old sunblock. There's a sign at the back of the sunblock, and it's like a pot. So this is a pot with the lid off. And what that tells you is how long after a sunblock has been opened will it be still, will it work still? Yeah, that's one more reason to use sunscreen. So that's solar elastosis. So you see the thickening of the skin, add that into rosacea and you get rhinophyma. The other thing with rosacea, it's important to consider camouflage and makeup. Again, you're looking for makeup that is fragrance and oil-free, and again, pretty much like the physical sunblocks, mineral-based makeup may be less irritating. There's also quite good green-based creams, and Boots do a really good one, number 7, which you can put on as a base across your cheeks, and the green kind of counteracts the redness, and your foundation can be put on other than that, or sorry, over it, and the redness doesn't come through. And the other thing is, remove your makeup gently and thoroughly at nighttime. Again, no scrubbing of the face. So certain things trigger rosacea, and each of you will have a different, it's very much an individual trigger. So we've covered sunlight. Certain spicy foods can make you flush or can make your skin flare up. Alcohol, that's where the whole whiskey nose comes from. Alcohol can make rosacea flare. Stress can flare anything skin-wise, including rosacea. Then strenuous exercise can also cause it, but it's not a reason to stop exercising or to stop getting exercise. And then certain types of cosmetics, you know, those very heavy foundations that require a lot of makeup remover and also waterproof mascaras, those very heavy makeups. So the treatments available fall into creams, oral antibiotics, and then there's a couple of other treatments. So these are not available across the counter, so you'd go to your GP and they'll prescribe these creams. So the top one is metronidazole. So that's an antibiotic cream that's applied twice a day. Azelaic acid isn't an antibiotic, and it's a retinoid, and that's twice a day. And this one, Mirvaso cream or brimonidine, is really for redness, for treating redness. It's to actually stop the blushing. I think where it's very useful for is if you're coming up to a wedding and you have that really high coloring and you want to not look red in the photographs, using it for a couple of days beforehand can work. Problem with it is you can sometimes get rebound, so when you stop it, it can return. And then ivermectin cream is, brand name is Soolantra, and that works against the Demodex mite. All the creams can feel a little bit stingy, but particularly Soolantra when you begin using it, but that usually wears off after about 7 to 10 days. So then if your topical, or if your creams aren't working, you move on to oral antibiotics. And it's important to note here, you're not using the antibiotics for their antibiotic effect. You're using them for their anti-inflammatory effect. So it's not like an antibiotic that you take for a chest infection or a kidney infection. And these are tetracycline antibiotics that we use for acne. And usually you take it for 3 months. And then what you're hoping is that you might need a course of 6 weeks of an antibiotic, maybe 2 or 3 times a year. Some patients don't get to that level of control, and if you need the antibiotic on an ongoing basis, then you may have to take it on an ongoing basis, but just having checked liver function tests, because they can cause your liver enzymes to go up every 6 months. But what you're hoping is that, you know, you will only need the odd course throughout the year. If you don't respond to antibiotics, then there is a medication called isotretinoin, and Roaccutane is the market name for it. And that's what we use for patients with severe scarring acne. And it works very nicely in rosacea, and usually in a lower dose and for a slightly shorter period of time. The main side effect is that it dries out your lips and your skin can feel dry. And we also monitor your liver function tests and a thing called your triglycerides, which is a form of cholesterol. because very rarely it can cause problems with your liver and a thing called pancreatitis, and because of that also there's no alcohol while you're on the medication, because alcohol can do the same thing, so you're adding two things together. And very rarely it may affect moods. We always warn patients just to keep an eye on your mood. The good thing about Roaccutane is in some patients you can actually stop the medication and they get a very good run out of their skin being good. And then there are some patients who may need a very low dose of the Roaccutane, maybe once or twice a week on an ongoing basis. So the other treatments that are useful in rosacea are laser treatments, and they fall into two types. There's the intense pulsed light treatment, which treats the background redness and also the very fine telangiectasia on the face. It's given once a month, and usually patients need about 3 to 6 treatments. So it can feel like a snap against the skin. And then for those larger vessels, so you know when patients get, or when people get larger vessels, broken vessels across their nose, they need a different type of laser. It's what's known as a pulsed dye laser. Then there's treatments for that rhinophyma, that kind of thickening of the skin at the end of the nose. And there's two methods of doing this. One is with what's known as a carbon dioxide resurfacing laser. And that's where a laser almost cuts off the top layer of the skin, so you get shaping of the nose. You're removing that top layer of fibrotic skin. Or it can be done with it's a blade, it's kind of a long blade, which it's heated blade. It can shave off the top layer of skin. There's a little bit of downtime with post-surgery, but can be very effective. The other thing, it's important to look after your eyes if you have that dry grittiness associated with rosacea. And there's simple things you can do in the morning if you've got scale across your eyelids. Just boiling the kettle, let it cool, putting a small amount of water into a egg cup and a tiny drop of baby shampoo, and using either a cotton bud or a piece of cotton wool to clean the edge of your of your eyelids. And if you're traveling, you can buy these wipes that are called blepharoplasty wipes in the pharmacy, but you know, baby shampoo is perfectly good as well. The other thing too is if your eyes are dry, to make sure that you use an eye drop, a lubricant eye drop, and there's loads of different types that you can get in your pharmacy. The other thing is treating your seborrheic dermatitis. So it's essentially overgrowth of a yeast on your skin. So an antifungal shampoo will work. Remember, the shampoo needs to go on the scalp, not the hair. So you put the shampoo onto the scalp, you leave it on for a couple of minutes, and then you wash it off. And you can use the foam to wash the eyebrows or the beard areas. And an antifungal cream can be used for the scaly areas around the nose. So those are my references, or they're good, there's good patient information leaflets that you may want to look up.
Thank you so much.
You're welcome.
Thank you. We want to thank Professor Anne-Marie Tobin. We hope that was very helpful discussion around the condition of rosacea.